Hi, good evening, everybody, or afternoon or morning, depending upon where you are and you're joining us. I'm Susan Thornton with the Cutaneous Lymphoma Foundation, and today we're going to be talking about Mogamulizumab. And our guest tonight is Dr. Pierluigi Porcu, who is the Division Director of Hematology, Malignancies, and Stem Cell Transplant at Thomas Jefferson University Health System here in Philadelphia. So welcome, Dr. Porcu.
Hi, Susan. Good evening or good morning, and welcome to the webinar. Glad to be with you.
Yeah, thank you. We really appreciate you joining us. And as you probably can appreciate and understand, with the recent FDA approval of Mogamulizumab, it is a hot topic, and a lot of our folks in our patient community have been watching and waiting for this, or people that have been on the clinical trial are now also anxiously looking forward to what's next now that we have FDA approval. So we wanted to spend this evening chatting only about Mogamulizumab, and you were one of the principal investigators as part of the Mavoric trial. And we have been connected with the team from Kyowa Kirin, who's the company that supported the trial and has the drug since I came over to the foundation in 2011. So it's been a while to get from start to finish, and I have a feeling was probably a few years before I was aware of the clinical trial at the beginning. So it's been a long time coming, but here we are. And the second in one of two systemic new agents that we actually have gotten approval for, brentuximab vedotin, that we got label approval for last year for cutaneous lymphoma. So, really exciting stuff, at least from my perspective, because we haven't had any new systemic therapies for a long time. And this is hopefully going to be helpful to a lot of folks. So I thought we'd start. I know you've got a presentation that you're going to take us through, but maybe just a little background around. This is something called a monoclonal antibody. And I know a lot of people, because it's an infusion, sometimes people say, oh, it's a chemotherapy. Maybe you can just start by putting this particular drug into the right context, and then I'll let you roll kind of right into talking about the trial and some of the outcomes and so forth.
Yeah, thanks, Susan. I definitely share with you the excitement about the fact that these trials have been completed, and of course the drugs being approved. That really kind of brings a lot of hope to a lot of patients with mycosis fungoides and Sézary syndrome that did not have other treatments available. But I think also it's very important in terms of the community, the scientific community, to really have, in the public, to really have, data from randomized clinical trials finally available in CTCL, something that we have discussed many times in the past was really necessary to understand better the natural history of the disease, to have confidence on the endpoints and the outcomes that we're looking at. So, I mean, it's great. It's been, as you mentioned, it's been long in coming, but it was all worth it because now we have very robust, solid data on both these randomized clinical trials. I know that you and Steve presented the brentuximab data a little while back. Now, to address your question on monoclonal antibodies. So what are monoclonal antibodies? Just like the name says, these are antibodies. So these are normally produced type of proteins in the body that target specific antigens, specific molecules on the surface of cells. And the only difference compared to the natural ones is the fact that these antibodies have been re-engineered in a number of different ways, which I'm going to explain in a second. But they have been re-engineered to be more functional, to have better performance, so to speak. And then most importantly, they are all exactly the same. So all tiny little clones of the same antibody. The way this is being done is through a variety of technologies, all related to recombinant DNA technology. Pharmaceutical companies now have the ability to produce monoclonal antibodies against just any antigen that can be targeted with a regular antibody. So this is what monoclonal antibodies are. A good example for I don't know if the audience is familiar with that, but a good example would be an antibody called Rituxan, which was produced and approved in 1997. It's been around now for a long time. So that was the very first monoclonal antibody approved for lymphoma. Another one is called, for breast cancer, is called Herceptin, which was approved for breast cancer a little before that. So talking about Mogamulizumab, which is the monoclonal antibody that was used in the Mavoric study, it has a couple of additional features, if we want to say it that way. The first is that it's a humanized antibody. So really, it means that most of the structure of the antibody is made of sequences that are human, from the human gene, and that is important to minimize the risk of developing an immune response against the antibody. And the second feature is that it has been removed a particular series of sugar moieties that normally are present on the antibody. And by removal of those sugar moieties, the antibody is much more effective in mediating the anti-tumor effect through the cells of the immune system that bind to the antibody and eventually kill the tumor cells. This is called defucosylation. So it's a really highly engineered, sophisticated monoclonal antibody, and it's directed against this antigen called CCR4, which is an antigen present on normal cells as well, in particular a subset of normal cells, not all the T cells, but it's particularly intensely expressed on the tumor cells in mycosis fungoides and Sézary syndrome. So that was a good target to use for T-cell lymphoma, and it proved to be effective in the end in this trial. I have to say that Moga is also approved in Japan for other type of T-cell lymphomas. One is called adult T-cell leukemia lymphoma, and the other one is peripheral T-cell lymphoma. So there was quite a bit of experience already from Japan with the use and the efficacy of this antibody.
Oh, that's good to know. So, and then this trial, the Maverick trial, was specific to cutaneous lymphomas.
That is correct. Yeah. So, okay. So the Maverick, it was designed as a randomized phase 3 trial, open label, which means that patients treated on one or the other arm of the trial, and their physicians, they knew the treatment that they were getting. It was a multi-center international study, and randomized, which means that patients did not, or their doctors did not select which treatment they were going to receive. It was kind of a random computerized selection of the treatment. And the two treatments, we call them arms. The two treatment arms, where one was the control arm, so a standard of care. It's a medication called Vorinostat, which belongs to a class of drugs called HDAC inhibitor, histone deacetylase inhibitor. It's been approved for a while. It's an oral medication, and patients were taking 400 milligrams of Vorinostat daily. And the patients on the so-called experimental arm, the investigational arm, were receiving Mogamulizumab, 1 milligram per kilo, weekly for the first 4 weeks, and as the schema shows there, and then every other week for the subsequent cycles. One cycle was 28 days for both drugs, and patients were continued on treatment until they had progression of disease or they had a safety event, that some toxicity or intolerance that required them to discontinue the drug. The design of the trial was such that for patients who were receiving the standard of care with Vorinostat, if they progressed after a careful evaluation of the criteria for progression, they were allowed to be switched essentially to the investigational arm with and go to and receive Mogamulizumab, something that is called a crossover at progression. This was a very large clinical trial that enrolled patients with stage 1B to 4. So it is a very broad spectrum of stages of patients who had received at least one prior therapy. It was 372 patients, so very, very large trial. You know, the diagnosis was confirmed histologically, so everyone had to have a biopsy to prove that they had mycosis fungoides or Sézary syndrome. And what we call the endpoints, which essentially are what are the goals that we are going to assess to see whether the one treatment is more effective than the other. The primary endpoint was something called progression-free survival, which essentially means the time that goes from the enrollment on the study, so from the moment the patient starts, all the way to the time that the patient has an event that is defined as progression of disease. So either a relapse if they were in a complete remission, or a progression, so increase in the burden of disease if they were in a partial response. That's kind of a very, very typical endpoint for randomized clinical trials of this size. There were secondary endpoints, meaning not only the progression-free survival, but also what the response rate was, what the duration of the response rate. And then there were a very large number of key, very important endpoints looking at quality of life measures, including patient-reported outcomes that were embedded in the design of the study that we definitely would be happy to discuss later in the program. So this was the design of the study. Susan, do you have any questions about this, or should I go on?
Well, I was just gonna say, so a couple of things to really highlight. So this, from what I understand, and correct me if I'm wrong, was the largest clinical trial that has ever been conducted in cutaneous lymphoma with the over 300 patients, which is pretty amazing when you think about the fact that, you know, these were folks that had one prior systemic therapy. So you're talking about people that had more challenging disease. And then, you know, this is an infusion versus Vorinostat, which is a pill form. So a little bit different delivery mechanisms. And when you talk about the control arm, you know, we really didn't have a lot of options to choose from, because really the only two, and you can correct me if I'm wrong, options would have probably been Vorinostat or Romidepsin, right? To kind of say, this is the standard of care that we have today. This is the new investigational treatment, and we're going to look and see if what we believe to be true of the new treatment has a better outcome than the current standard of care, because that's what we're trying to find, right? Are things that are better and more effective, longer remissions, or all of those endpoints that you talked about. Right. And then the other big part of it was the quality of life indicators, which I think, if I recall correctly, this was really one of the first trials that included those kinds of quality of life measures, which is a big deal, because then we get to look at not only the clinical data, but what was the impact on the patients that participated, and how does that then play into the overall life of people living with the disease and going through treatments. So, you know, pretty exciting and pivotal in our world. Maybe it's happens more often in larger, more prevalent diseases like breast cancer or other diseases. But for us in cutaneous lymphoma, this was a pretty big deal.
No, I agree. Definitely a big deal. You're right. This is the largest randomized clinical trial in CTCL. Rick, I think that you know, you're also right in regard to the selection of the control arm, which is you know, the FDA, you know, they want to have a FDA approved standard of care as an ideal comparator, you know, to compare with the other drug. And Vorinostat and romidepsin really were kind of the only drugs really kind of available for that. Most of these patients, they had one prior systemic therapy, drugs like bexarotene, so Targretin, or Methotrexate, or interferon. Most of the patients already had exposure to some of those drugs, so none of them could have been really a good and appropriate comparison. And regarding the quality of life, I think that even though the quality of life tools were also used in the clinical trial for brentuximab, but actually the intensity and the frequency and the scale and the diversity of the tools used to measure quality of life in the Mavoric were really not paralleled by any other in the trial. So I think that this is already producing a lot of data that are going to be very helpful for patients and in other agencies to look at when we try to define what the best outcomes really of treatment for patients with CTCL. Now to go to the, I have a next slide that shows kind of a distribution of the patient's features. This is a standard way of analyzing and displaying the data. As you can see, you know, patients were well distributed really across the Moga and the Vorinostat arm, where, you know, that this is a typical population of patients with mycosis fungoides and Sézary syndrome that we see. You know, the majority of the patients were older than 65. Kind of the female, you know, to male ratio is about what we expect it to be. There was a significant number of African American patients on the study, even though not as much as, you know, the representation of patient with, you know, African American patient with CTCL that we see, particularly in some areas like here in Philadelphia, for example. And I think that, but the single really most remarkable fact about this clinical trial is the number of patients with Sézary syndrome that were enrolled. As you can see in the table here, 168 patients overall with Sézary syndrome. This by far is the largest number of patients with Sézary syndrome ever treated in a uniform, prospective way with any drug, really. So the value of the data that we're getting from the Maverick in terms of the, you know, the response of patients with Sézary syndrome, you know, what the dynamics of the response is, you know, what the side effects are. This is really never done before. So very, very, very important set of data here in general, but specifically for patients with Sézary syndrome. And you know, moving forward, I think that one of the, so how do we look at the efficacy outcome, which was the primary endpoint for the study. Again, remember, you know, the primary endpoint was what's the progression-free survival. That graph to your left is something called Kaplan-Meier curve, which essentially is what's called an actuarial analysis of patients, you know, progressing, you know, after their initial treatment, and you may not see them, but there's a lot of little ticks on those curves which represent individual patients. You follow patients, you know, for a long time, and you know, the red curve is the curve of the patients with treated with Mogamulizumab, and the blue is the one the patient treated with Vorinostat. And as you can see, there is a wide difference in terms of the progression-free survival for those two curves. If you kind of move to the right, where the table is, on the left of the table, you have the different endpoints. On top, of course, is the median progression-free survival, which was 7.7 months for Mogamulizumab and was 3.1 months for Vorinostat. So just based on that, in terms of the primary endpoint, Mogamulizumab was superior to Vorinostat, and that's sort of one of the primary reasons why the drug was approved by the FDA. But Mogamulizumab did better than Vorinostat just about across every possible endpoint. So if you look at the overall response rate, it was 28% versus 5% overall. Again, if you break it down according to mycosis fungoides or Sézary syndrome, the response rate in mycosis fungoides was 21% versus 7%. The response rate in Sézary syndrome, that's the widest difference. You see 37% response rate with Mogamulizumab, 2% with Vorinostat. And then, just looking at the response rate of the crossover, which means that patients who were started on Vorinostat, the disease progressed on Vorinostat, they were switched to Mogamulizumab. How many of them responded to Mogamulizumab? The answer is 30%. You can also see from there that 136 patients that were on the Vorinostat during the course of the trial had to switch to Mogamulizumab, which is another indication of, the strength of the therapy. And if we look at the duration of response, which that's the last one, it's in terms of months. It's significantly different, and again, both for mycosis fungoides as well as for Sézary syndrome, in particular for Sézary syndrome. So this is kind of a snapshot, global landscape view of the activity of the two drugs. Remarkable the difference in terms of the efficacy with Sézary syndrome, but also very significant and clear the difference in outcomes for mycosis fungoides between Moga and Vorinostat. Susan, any questions about this? Any comments?
Yeah, one thing as I'm thinking this through, since I tend to listen to the science a little more, I'm trying to put my layperson's hat on. So what's the difference between progression-free survival and duration of response? To me, they seem kind of similar.
It's a great question. So the duration of response is the time interval between the moment someone actually has a response and the moment that the disease, at the moment that the response is lost. Progression-free survival, on the other hand, starts from the moment the patient gets on trial. So progression-free survival will include all that window of time when the patient gets on trial, they start therapy, they receive therapy, and all of that. None of that particular time window is included in the duration of response. So I think that the fundamental difference is that a much larger fraction of the patients, almost all patients, except for those who fall off study for reasons of eligibility, will be included in your progression-free survival data set, right? Will be counted for progression-free survival. On the other hand, the duration of response is only counted on the patients who get a response. So in other words, if you don't get a response, then you're not going to be included in the duration of response calculations. Does that make sense?
Yeah. Yeah, so I'm just thinking again, if I'm a patient who is interested or Moga might be an option for me, I think that it's great that we were really looking at the duration of response, even though that wasn't the primary focus, because, for us, that window of time where you have stabilized and maybe even better disease for the longer period, the longer we can go, to me is one of the more critical numbers to kind of look at.
Yeah, and I would say that the durational response sort of information is included in part in the progression-free survival curves as well. But I think that, you know, definitely the durational response is more specific. You know, if you're a patient, for example, who is getting Mogamulizumab or any other drug, and you don't get a response, meaning that you don't hit that particular benchmark that, you know, in clinical trials is to have a partial response, you need to have at least a 50% reduction, say, in your skin, you know, surface involvement. Then if you don't hit that, then the durational response could be less important for you, and you know, and is not particularly relevant. But if you have a good response, especially if you have a complete response, and this doesn't break it down according to complete versus partial response, but then I agree. You know, maintaining the response long term is probably the most important value there. Let me just add one thing. Keep in mind that the value of maintaining a response could easily be different in patients who have earlier stage MF, for example, as opposed to have more advanced stage. So if you have, you know, 1B disease, I think that losing your response might not have the same severe impact and consequences as if you have, you know, Sézary syndrome or stage 4 disease. That's why it's so remarkable there to see that the median durational response for Sézary syndrome was 17 months, which is very high. But you see that the numbers on which that durational response was counted is significantly less compared to some of the other, to the overall denominator.
Right, right. Great. And I'll just jump in to let people know to send in your questions as you think of them, and we'll try to take them as we go, or we'll open it up for questions at the end as well. But if you have a question and you want us to answer them, feel free to text it into the chat box, and we'll address them as we go.
So one of the important things about any clinical trial with particularly with new drugs, and for new drugs that are kind of aspiring to get to the market, is of the question of the safety of the new drug compared to the standard of care, the type of side effects, and the frequency of the side effects. And this table, kind of, which is based on the paper that was published in Lancet Oncology that Dr. Kim from Stanford was the lead author on. Again, all of this is published, so you can find it in the Lancet Oncology. Essentially, this gives you a landscape view of all the different type of toxicities, and the most common ones occurring with Mogamulizumab and Vorinostat. So if you look at the tables there, the single most common adverse event for Mogamulizumab was something we call infusion reaction. As you mentioned, Susan, Mogamulizumab is it's an intravenous drug, is given as a drip, and just like with any other monoclonal antibody therapy, as it was with Rituxan back in the late 90s when it was approved, the most common side effect is an infusion reaction, which means that as you're getting the drug infused, pumped in, after a while you can develop some fevers, you can have rigors, chills, sometimes, or a rash, sometimes hives, you know, and any one of those things, sometimes asthma, any one of those things can happen. And 33% of the patients who had Mogamulizumab had at least one type of those, you know, one severity of that reaction. And a relatively small amount of them, you know, 1.6% had severe infusion reactions. Obviously, none of those things really occurred with Vorinostat because Vorinostat is a pill. The second most common side effect of Moga in the trial was a skin rash, which may sound ironic considering that the patients with mycosis fungoides, go into the trial with a rash. But these were they were not always easy to distinguish. But clearly, the drug has an immunomodulatory effect. So it kind of modulates, in addition to killing the T cells directly, but also has an effect on the immune system. And it's very, very common to actually develop rash following a treatment that modulates the immune system. So altogether, almost 24% of the patients had a skin rash, and in 4.3% was severe enough, to be called grade 3, which means that you need to do some treatment, topical steroids and itch, symptoms and all of that. Now, again, none of those two things really happened with Vorinostat, but that was not unexpected. If you go back to the other ones, diarrhea, fatigue, nausea, all those side effects occurred with both drugs to some degree. Now, as you can see with Moga, most of the times it was mild, and only rarely it was more severe. But in the Vorinostat arm, the frequency was significantly higher, and also the frequency of the high severity subset was higher, because those are the typical expected side effects of Vorinostat: diarrhea, fatigue, nausea. Another one, which is listed down there, is thrombocytopenia, which means a drop in the platelet count. And drop in the platelet count is a class effect of histone deacetylase inhibitors, like Vorinostat, so was observed as expected in a significant fraction of the patients. In some patients was severe, so with a platelet count less than 50,000 or less. And it really did not happen in any significant degree with Mogamulizumab. Only 11% overall, and no patients with Mogamulizumab had severe thrombocytopenia. Same for anorexia or decreased appetite. 24%, almost 25% of the patients with Vorinostat had it. Less than 10% of the patients with Moga. Dysgeusia, which is interesting word, it's actually a change in the quality of the taste. So food that doesn't taste the way it used to. That's a very common effect in Vorinostat, 30%, almost nothing in Moga. And then increased blood creatinine, which is a symptom of kidney function. With the higher the number, the worse the kidney function being. 28% in Vorinostat and 6% with Moga. So overall, even from the standpoint of the severity, even if you sum it up, the frequency of overall adverse reactions between Moga and Vorinostat was not that different. But the reason was that some side effects only occurred with Moga, as was expected, and most of the other side effects really occur predominantly with Vorinostat. So altogether, the side effect profile clearly shows that Mogamulizumab is a safe drug to use, and that, of course, that's one of the reasons why the FDA was convinced by the data to approve it. And these infusion reactions and skin rashes were not. First of all, the infusion reaction stops as soon as you stop infusing the drug. So none of that is persistent, and the skin rashes were actually were treated effectively with topical therapy, sometimes systemic therapy, but definitely nothing that really persisted long term.
So I was just going to say,
questions from the audience about that? Yeah.
Well, I think, just in clarifying, because I think some of the information that was out, when it hits the airwaves and so forth, and you start to look at the overall statistics, right? And before you're able to dig down behind the scenes, it may look a little different. And I think maybe if you can explain a little bit between how you grade these adverse events, because I think everything I know, an aspirin has adverse events, right? And probably there's some statistic out there somewhere where somebody may have had a life-threatening adverse event with aspirin, right? So the clinical trial is trying to understand those and capture them. Sometimes they all get rolled together, which may, and unless you're really looking deep at the data and doing the analysis from the clinical perspective, as a layperson, you may not fully know what that means, and it could be pretty scary. If you see like, oh my gosh, all of these adverse events, my heavens, what could that possibly mean? How could this drug be great or a good drug?
Yeah, no, that's a good point. So first of all, I think, the one thing about clinical trials is that we count every adverse event. When you get treated, as you said, with aspirin, for example, or you get treated with penicillin or any other antibiotic, typically you don't go through a exhaustive list of possible complications, or like your blood pressure medication or your diabetes medication. So if you were to go through it just like this, then the list would look just as long or potentially even longer. So that's the first thing. So that's the first thing to keep in mind. The second thing is regarding the grading. It's a great question. The grading really comes from the fact that in doing clinical trials, you have to have a system to measure consistently across multiple different institutions or multiple different sites, how the severity of a certain toxicity is measured. And that's why these rules, which are designed by the NCI and are used for clinical trial, that everyone uses. So so for sure, a grade 4 diarrhea is the same diarrhea whether it's here in Philadelphia or in California or in Poland, for that matter. So that's the thing. The second thing is the severity of the adverse event does not necessarily imply that it is a life-threatening adverse event. For example, grade 4 nausea, it's a type of nausea that requires you to be treated, potentially go to the hospital to get intravenous fluid and anti-nausea medications, which of course is not pleasant and is not fun, but is hardly kind of a life-threatening event. Grade 4 fatigue, for example. So most of these things, not all of them, but most of these things can be graded grade 3 or grade 4, and therefore being considered severe, but not necessarily life-threatening. So I think that there's a lot of confusion about what that, how the correspondence between the two gradings is. And I think that some of that confusion actually is showing up in some of the news releases some of the news that are reported around, where there is a kind of a confusion between the severity of the reaction based on the grading and whether or not they're actually life-threatening. So I think that, so if I look at the profile of Moga or even Vorinostat, actually, there's nothing in that profile of toxicity that really kind of shows that neither one of these two drugs is highly toxic in any way. What's showing is that the toxicity is different. And again, with Moga, it's mostly infusion reactions, a skin rash, and with the Vorinostat is all those, GI, diarrhea, fatigue, a lack of appetite, things that we have seen, that we know quite well from all the use of Vorinostat over time. Does this help, Susan, or do you think? Or
yeah.
Okay.
Yeah, no, I think that's good. I don't know, Mike, did you want to jump in?
Yes, Susan. Let me just come on. Thank you. Let me just bring myself on the screen here. Dr. Porcu, as I mentioned before the show, and as some folks in the Sézary syndrome group know, my mom was in that phase 3 clinical trial for Mogamulizumab. She was initially randomized by flip of an electronic coin to Vorinostat, and then as per the the trial protocol, she had to wait until her disease progressed by a certain amount, and then she was able to, as you mentioned earlier, switch over to the Mogamulizumab. She had one of those infusion reactions, and we had actually spoken with another patient on the phase 3 trial who had an infusion reaction a few weeks before my mom was treated with Mogamulizumab. And this other patient, a wonderful woman, Yvonne DeSimone, who sadly has since passed away from another form of cancer, but she shared with us so much insight about her own experience on that trial, where she too had an infusion reaction, and her doctor hypothesized that it was because Yvonne had a high tumor burden of Sézary in her blood, and so as a result, maybe she had sort of that reaction. So, we were prepared and aware of that possibility because my mom's tumor burden was even higher going into that infusion. And after an hour watch and wait period at the hospital after my mom's infusion, when everything was fine, she felt fine, she had a sandwich. We were driving home, and 30 minutes into the ride, so 90 minutes after the infusion, she had that reaction on the ride home, and I had to pull over. We called the hospital where she was, received the infusion at Yale, a center of expertise, and they told us to get my mom to the nearest hospital, which was in Hartford, Connecticut, and that she was having an infusion reaction, and they treated her with prednisone. It offset the reaction, but she experienced some significant symptoms. She had excruciating pain in her hips and her legs. She had extreme chills. She had nausea. It came on very quickly, but with the prednisone treatment, it really offset it pretty quickly, and within a day, she had a dramatic improvement in the lessening in the amount of Sézary in her blood by something like 60 or 70%. And but she had to leave the trial. She wasn't allowed to stay in the trial because it was considered a grade 4 adverse effect, and so she had to leave the trial. And she subsequently went on Romidepsin, and within a month, the Romidepsin got rid of the rest of the cancer, and she's enjoyed a complete remission now for 2.5 years since. So we are big fans of Mogamulizumab, at least from our, anecdotal experience. But I just wanted to share that because it was a grade 4 adverse effect.
No, I totally agree with you. And the infusion reactions, particularly the severe ones, can be very scary. We meaning the oncology doctors, we've been sort of managing and dealing with infusion reactions now for 20 years, essentially, again, since Rituxan came on the market. And you can get exactly the same severe adverse reactions with Rituxan for B-cell lymphomas or B-cell leukemias. I think that there is there's a learning curve as well in terms of how to prepare patients for the infusion. I think that with the drug approved now, what you can do is you can give a pre-medication to with a steroid perhaps for more than one day if necessary. I think that there are ways, or for patients who have very high, lymphocyte counts in the blood, say like 50,000, 60,000, 80,000. Sometimes what we do is actually we give them steroids for a few days to kind of, dexamethasone to reduce that. The pre-medication is going to be also important. So I think that infusion reactions will continue to be seen for sure, just because it's so common and it's typical of the antibody therapy. But I think that in terms of now that the drug is on the market, is going to be used, I think that the mitigation of the infusion reaction, the measures to do that are going to become fairly diffuse, and people using the drug will know how to do it. If any oncology, for example, has never used Mogamulizumab, I think that they should definitely, find out and learn about the drug. The package insert, has all the information necessary to kind of to deal with preparing the patient for that. So It's clearly a class effect of monoclonal antibodies. It's not specific for Mogamulizumab. This happens with any antibody. So any physician that is experienced in treating cancer patients with, especially with leukemia, lymphoma, will know how to deal with that. So let me, because I know that we're kind of getting to, first of all, thanks for your question, Mike. And I'm glad to hear your mom is doing so well, by the way. So I wanted to briefly discuss the quality of life because I think that, as Susan mentioned, the Mavoric was really is really the first clinical trial to be so data intense on the quality of life. And this is fairly technical, so I'm not sure I'm going to go through all the little details. But the bottom line is that the patients on the trial were asked to complete a number of questionnaires associated with the quality of life. And if anyone in the audience has been on the trial, they will know exactly what I'm talking about. And one is called the Skindex 29. The other one is called FACT-G. And then there's a European scale, and then there was an ITCHY scale. None of these scales is perfect, and they all have to be taken in consideration when looking at it. But I think that the first thing to show is that the compliance in terms of the fraction of the patients who was able and willing to complete all these questionnaires was very high. More than 90% of the patients really completed all the things that they were asked to complete, which is major. Because, once you go to your treatment and you have to have other things to do, then I'm not sure you're in the mood to fill like a 5-page questionnaire. But this was great, and this gives really a lot of confidence in the data. And the bottom line is that, if we look at the changes that occurred on treatment with Mogamulizumab, and here in the figure is in yellow, versus Vorinostat, either Mogamulizumab was significantly better than Vorinostat in a particular scale, or Mogamulizumab was the only sort of drug that really produced an improvement. For example, right there on the left lower corner on the FACT-G, that you see that the patient treated with Mogamulizumab actually had a clear improvement in their quality of life. A patient with Vorinostat actually had a worsening of their quality of life. So, and then there was improvement really in terms of the scales on all points. So I think that this also is something very important and that's all the slide I'm going to show. Also very important in sort of persuading the regulatory agencies of the value of the drug. These were not the primary endpoint. But I think that for patients, in terms of the clinical benefit, it's clearly very important to know that the itch, for example, gets significantly better with Mogamulizumab. And as you know, if you have Sézary syndrome, itch is your dominant, overwhelming symptom. So very important to have that symptom improved. I think that's all the slides I'm going to show, Susan. I'm happy to take more questions from you or Mike or anyone in the audience.
All right, so we've got questions lined up for you, so here we go. What are the requirements for being approved for Moga? My mother has been taking Vorinostat for almost 4 weeks. This is her first treatment since diagnosis.
What are the requirements to be approved means what are the specific indication that one has to be eligible to receive Moga as a standard of care now that it is approved, is essentially to have failed one prior systemic therapy. And so I think that if this person's, if your mother has been on Vorinostat for how many weeks? You said 4 weeks, 5 weeks?
4 weeks.
4 weeks. I think everything depends on how is she doing on Vorinostat. If she's not doing well on Vorinostat, and 4 weeks is a relatively short period of time with any drug, then assuming that the physician treating your mom can can make a conclusion that the Vorinostat is not effective and is not producing a response, and therefore that your mom is quote unquote failing Vorinostat, then I think that the patient will be eligible to be treated with Moga. So that's what the insurance company is going to look at in terms of the qualification to receive Moga. They look at the label of the drug, meaning the FDA label, and if it is a good match, then they will cover the cost of the drug.
And then there may also be some additional things to take into consideration, like as we said, Voriноstat's a pill, Moga is an infusion, so sometimes those types of things also come into play. You know, how well people can tolerate the actual delivery method and things like that.
Yes, absolutely. And for the infusion, you have to come to the infusion center initially, every week, and then every other week. On the other hand, with the Vorinostat, it's a pill. Certainly much easier to take. In the end, you have to look at what the difference is in terms of the overall benefit is. I know a lot of patients who would rather come to the infusion center once a week and get their infusion done if they know that the treatment is going to be more effective than taking a pill every day, which is easier, but if it is less effective, then most people will not continue with that.
Right. Okay, next question. For Moga patients, is it true that their risk of severe or acute GVH disease is high, as well as mortality when they have a stem cell transplant? So I guess the question is, if you do Moga first and it obviously doesn't work over the course of time and you end up going through a stem cell transplant, does that increase your risk of serious complications after the transplant for GVHD, graft versus host disease?
Yeah, it's a great question, because I think that it's something that has been certainly in the scientific arena and also in the public domain for the past year or so. I don't think anyone has a final answer on that. I can tell you this. There are some reports that definitely have shown that within the patient population that those reports analyzed, there was a higher risk of graft versus host disease with allogeneic bone marrow transplant in patients who had received prior. Now, many of those patients did not have CTCL. So whether or not that is true in CTCL, I think it's still an open question. There is a publication from the Stanford group in the past, I think 6 months or so, on a small number of patients, but it's raising the question whether that may be true also in CTCL. And I think that that's something that definitely needs to be assessed better. But most of the data that really sort of made into the public domain about the risk were from patients who had adult T-cell leukemia lymphoma in Japan. And it's not clear to me that that is going to be true in patients with CTCL. So my approach to that is we don't know yet. It's not impossible, but I think that generally in science you really want to have a positive confirmation of something before making a definitive claim. So I think that in CTCL we don't know, but that it's a very good question. It's something that is on everyone's radar screen right now.
Well, and I think that is another point where just because the clinical trial has ended and we now have an FDA-approved drug, that doesn't mean that we stop capturing data and studying these different things and the longevity of side effects or other impacts. We continue to try to pull that data so that we can better stratify the right patient for the right treatment at the right time and mitigate the risks, right? So we still have a lot more work to do.
Oh, absolutely. There's a huge amount of additional work to do. I think that the company is supporting that additional work in the form of what's called investigator-initiated trial, which means that there are a lot of, now the drug is approved, a lot of people, a lot of investigators around the world that will come up with a lot of very good ideas in terms of how to use Moga either by itself or in combination with other drugs, and what the efficacy and the side effect profile of those combinations are going to be. And then even outside of clinical trials, as you say, Susan, there's a lot of learning that happens after the drug comes to the market in specific situations. So especially in the early phases of a drug approval, the first 5 years, I would say, people have to be sort of alert, to possible side effects or possible clinical situations that may not have emerged from the clinical trial. I mean, if you have a side effect, for example, that only happens, one every 5,000 patients, then you're not going to see it until you treat 5,000 patients with that drug. And even though this was the largest clinical trial ever done in CTCL, it only had 372 patients, right? So you have to keep those things in mind. Yes, definitely there is a lot to learn as we move forward.
All right, so next question. If a patient has had thyroiditis from a previous trial, is that a concern for trying Moga?
Wow, very good questions. So I would say no. And the reason I'm saying no is that, as opposed to some of the other immunotherapy drugs that now people are becoming quite familiar with, so-called, checkpoint inhibitors, where the risk of actually either inducing an autoimmune disease, and this is, of course, is assuming that thyroiditis that the patient is talking about is autoimmune, which in most cases they are, but not all. But as opposed to the checkpoint inhibitors, I think that the data about autoimmunity induction with Mogamulizumab are, just not there that I'm familiar with. So I don't think there is a high risk of developing a new autoimmunity or exacerbating an autoimmune disease with Moga. I'm pretty sure that it is not a contraindication to use Moga. That said, again, Moga has immunomodulatory effects. We think that some of those immunomodulatory effects come from decreasing the level of a type of T cells called regulatory T cells. And these T cells tend to suppress immune responses. So I think that, again, one would have to be careful about, being alert and maintaining attention to the rare things that could happen when patients being treated with Moga.
Right. So really, you've got to share all that with your physician, and then monitor these different things as you go forward.
Correct.
Okay. So, did the patient's age factor into any side effects of Moga? My mother's 79 and is stage 4B Sézary.
Okay. So, in the clinical trial, I don't think it did, but to be fair, I think I would have to go back and look at the tables to see if there was anything related to age about the side effects. I don't think so, but I would have to do due diligence and kind of looking specifically at certain age groups. Obviously, everything depends on how you look at age. I mean, it is could be anyone more than 65 or less than 65, or can you look at 80 to 90, 70 to 80, and so on, right? Certainly, I don't have that broken down that way. I can tell you that in the quality of life data set, The age was included as, everything was normalized according to age, and they were, being older or being younger made absolutely no difference in actually getting benefit from the Moga in terms of quality of life. But for the side effects, overall, I don't think so. But and I would not have it broken down according to specific age groups.
Okay, but again, something to work with the physician. If there's any other conditions of health that might have an impact just because of age.
Yeah. Okay. Yeah, you're right, Susan. Let me be practical about the question, which I think probably what the person asking wanted to have. I don't think there is a contraindication to. If I heard correctly, it was like 84, the patient, or 85.
Right. Yeah, okay. Something like that. Yeah.
So I don't really think that represents a contraindication to use Moga. I don't think that should be a reason not to use Moga, especially if there is a very good clinical reason to do it. I would say that, work with your oncologist to make sure that everything that is necessary to be done to minimize the risk of having, particularly having severe drug reactions, like an infusion reaction. Very important to do. Those are the patients I would go, I would stretch the pre-medication part. I would go the extra mile in doing, antihistamines, and Benadryl, and monitor closely, because the infusion reactions are very easy to deal with. In fact, if the patient is there. So if you watch a patient for 12 hours or so, or even overnight, potentially it can be done. I mean, I think that they're very easy to take care of those infusion reactions. They're easy to treat once you have them. So all that I think would be appropriate in an older patient.
Okay, great. When used for B2 blood involvement in FMF, does Mogamulizumab reduce the number of lymphocytes in the blood? So folliculotropic.
Yeah, so it's an interesting question. I mean, I think that, B2 blood involvement, which is, essentially synonymous with Sézary syndrome in the proper context, but in someone who has folliculotropic MF, the answer is yes. There's absolutely nothing specific about, folliculotropic MF or any regular MF with, blood involvement, B2, that would prevent, the cells from responding to Moga. So, yes, I think that I would expect Moga to work just as well in someone with MF who also has B2 blood involvement.
Okay, great. What else do we have, Mike? Mike, there we go. This is very direct. Moga versus methotrexate. Probably means it depends, right?
Yeah, it's a big depends, because I think that I have to admit that I don't use methotrexate very often for mycosis fungoides. And not to say that using it is wrong. And I know in Europe, for example, methotrexate is very frequently used. And I think that in some patients can be quite effective. I usually use methotrexate here in the US, my practice, mostly for CD30 positive diseases like lymphomatous papulosis, sometimes some anaplastic lymphomas. I also use it in patients with erythroderma, like the so-called erythrodermic CTCL. My personal experience is that for patients who have, B2 blood involvement, for example, or they have Sézary, methotrexate really is not very effective, although I'm sure there are exceptions. So everything, as you said, it depends. I mean, if we're talking about a patient with, say, 1B disease, or 1B disease, I would say, then perhaps, then the question is valid. If you have never used methotrexate, then you need to have systemic therapy. Why not? But I think that if we start going into tumor stage disease or Sézary syndrome blood involvement, I think that Moga is vastly superior, even though it was not the control in the arm. But my gestalt, my instinct would be that Mogamulizumab would be much better than Methotrexate in this. Now there are some data, that could be used. If the person who asked the question, in the audience, the person goes back and take a look at the Alcanza study, where Methotrexate was one of the 2 control drugs in the control arm, then you can see how patients did in that particular study. Now, you keep in mind that patients with Sézary syndrome were excluded from the Alcanza study, so you're not gonna learn anything about the treatment of Sézary syndrome Methotrexate from the Alcanza study. Patients with Sézary were, as I show, included in the Mavoric, and the efficacy that we see in the Mavoric, it's hard to imagine that it would be the same with Methotrexate.
Great. All right. Just joining, but my dad was on Ontac trial and had thyroid reaction. Can that happen with Moga?
I think it would be helpful to know exactly what type of thyroid reaction your dad had, because there are many different types and it's kind of hard to know. If it was kind of if it was an autoimmune reaction, I think that the odds of that are low. I used a lot of Ontac in the old days, and Ontac was a drug that could have some major systemic reactions, talking about like infusion reactions or sort of systemic reactions. And of course, some of those reactions could manifest themselves in many different ways: low blood pressure, inflammation, rash, asthma, and so potentially, I've never seen a thyroid quote unquote reaction to Ontac, but I can certainly imagine seeing that in the context of some generalized toxicity. But I think it would be good to know exactly what the person meant by thyroid reaction.
Got it. So in the interest of time, we're going to take 2 more questions. And we apologize if we didn't get to your question, and you can send them to us and we'll try to get an answer for you. So second to last question, the penultimate question. How soon will Moga be available for patient use?
I think that,
to the best of my knowledge, it's available, but it may just not have gotten out to all of the centers from a distribution perspective, is my understanding. But
this is a very good question, and in all fairness, this is a question that could probably be addressed more squarely and knowledgeably by the company. So I think my suggestion to anyone who has that question would be to contact your oncologist, or contact also the company, because I'm sure they have a hotline for this kind of question. But the bottom line, as Susan was saying, is that the drug is approved, the drug is available. Now there's a certain process that has to occur for a particular hospital or practice to actually being able to dispense. The pharmacy has to be involved, the drug has to be on so-called formulary, and that can take some time. So that's really the only limiting factor. Otherwise, the drug is available in general terms. So I would say talk to your physician, ask them if they have the drug, if they have gone through their pharmacy committee approval, and when they're able to, there has to be also some billing kind of infrastructure in place. So people need to know how much they're going to have to bill for the drug. And then if all of that is in place, then the drug is available. Yeah.
Right. And we'll try to do some research on that as well with some of our connections with the company. So I'm pretty sure there's Do you,
I
Go ahead.
agree. I think that's where the foundation could also help quite a bit
Yeah.
to do this groundwork for the patients. I think that the CLF could be very helpful in that.
Yeah. So we'll do some research on that, and we'll put that up on the website and send it out in an e-blast, so folks have that once we get it. Okay, our last question. How does someone get on a trial? Okay, well, that's a big question to end with.
How can one go on a trial, or how does one get on a trial?
I guess that's kind of a broad question, but if you're interested in becoming part of a clinical trial, what's the best approach? I guess start with your physician and ask about what clinical trials that may be opened. We also list a lot of clinical trials that are currently recruiting on our website. And then there's also clinicaltrials.gov, which can be a little bit more challenging. But in general, I would say start with your physician and check on our website to see what's open and available and recruiting people and what the criteria is.
Yeah, I mean, it is a great question, and a very important broad question about clinical trials. So I would say a couple of things. One, as Susan mentioned, your first thing is always, to sort of check with your primary oncologist or dermatologist and see what's available and whether there's anything that you would be a good candidate for. That's the first thing. The second thing is, clinical trials may or may not be available in the either in the institution or the practice where you're being treated, or in the proximity. And so then the next question is going to be, if there is a good clinical trial that you would be a good fit for, what's the closest place that you could get on? One of the issues with clinical trials, and one of the problems, is that in most cases you have to have your treatment given at the place where the clinical trial is open. And you cannot just go enroll in a clinical trial and then do all your treatment, say at home in a different place. That's a challenge. And then finally, let's say that you identify the clinical trial. It's the right clinical trial for you. You can do it in the sense that it's logistically is doable. Then there are some more specific issues about something called screening, eligibility, and that means that there's a certain process of verifying to make sure the diagnosis is right, make sure that all the the clinical criteria, organ function, laboratory test, functional status, all that is appropriate, because clinical trials will have some very specific entry criteria, which not everyone will match, and therefore, you may want to be in a particular clinical trial, but there is something, for example, kidney function may not be good. Okay, that will make you ineligible for that clinical trial. That's one of the most frustrating things for patients to go through, and that's why it's important to have a very clear communication with your physician, because your physician is going to be able to navigate all those things quickly and much more efficiently on your behalf than most of you will be able to do, so that you don't travel 500 miles to go to a place just to find out that you're not eligible for that particular clinical trial.
Right, that's a very good point. Very good point. And let us know if we can help. We'll do our best to try to help folks navigate to the right opportunities. So that's it for tonight for Mogamulizumab. Thank you, Dr. Porcu, for joining us and for sharing all of your wonderful knowledge and experience, particularly about this new and exciting drug. And I know we'll be gathering more information and continuing to see how this all rolls out in the future, but it's an exciting option for a lot of folks, and looking forward to seeing seeing more people have access and an opportunity to try this. So a couple things before we go. I just want to remind you that we will be in Palo Alto on Saturday with Dr. Kim and the team from Stanford for our full day patient program. So if you live in the San Francisco Bay Area and can join us, we would love to see you. And check out our Facebook pages. We have news and insights you can use for both mycosis fungoides and Sézary syndrome. We try to, and Mike, as you know, who helps to produce these Facebook Live programs, also manages those for us, and he tries to find information that's very top of mind and of interest to folks in those two specific areas of disease. Just sometimes those are a little different, sometimes the same, but sometimes very different. And of course, as always, if you enjoyed the evening and you found this valuable and you think that we should continue to bring these kinds of programs to you, please consider making an investment in the foundation so that we can continue our work and continue to do innovative and more of this kind of programming. Now I sound like a public radio, but public, you know, for all of you to bring this information to your doorstep and into your living room via technology. So anyway, that's it for us this month. We'll be back next month with another round of our Facebook Live interviews. And again, Dr. Porcu, thank you so much for joining us and for spending the evening with us. And we'll let you go home to your family and say hi to everybody for us. And thanks everybody for sticking with us and for all your great questions. They're always fabulous. And if there's anything that we can do for you, drop us a note, send us an email, give us a call. We're always happy to help in any way that we can. So thanks everybody. Have a great night or a great day, no matter where you are in the world. And we'll see you again next month. Bye.
Thank you, Susan. Bye-bye. And thanks, Mike, for setting this up.